first up, we have Claudia Ramirez. She's a sub intern born and raised in San Juan, Puerto Rico. She completed her bachelor's degree at Manhattan University and upon graduation at Pfizer Vaccine Research and Development for 2 years. She's currently completing her medical education in Puerto Rico and is applying to Urology Match this cycle. Please welcome her for her presentation.
So good morning, everybody. Today I'm going to be talking to you about fertility considerations and advancements in prepubertal and pubertal children with testicular cancer. Soam did a great job introducing me, so I'm going to skip this part. First, I want to talk to you about why I chose this topic. So 2 weeks ago, we had resident training, and we talked about testicular cancer. And at that time, we talked about management, treatment, fertility. And I had a question on what would happen to prepubertal kids who had testicular cancer in terms of their fertility considerations. And during the resident training, we really couldn't come up with a good, solid, what to do. So I decided to choose that as my topic and fill the gap with some information for you guys. So testicular cancer is a rare occurrence. It's about 1 to 2% of all pediatric solid tumors. About 1.6 in 100,000 kids under the age of 15 are affected by it. Their most common tumors, if we divide them in prepubertal and pubertal stages, the prepubertal is germ cell tumors, stromal tumors, and they tend to be benign. And in pubertal, it's germ cell tumors, and they tend to be malignant. Here is a algorithm on different germ cell tumors with the precursor cell and differentiation into the different ones. So the survival rates for testicular cancer, if it's a stage 1, stage 2, which is localized to the testes, has actually pretty high survival rates, about 95%. And stage 2, which is advanced cancer, the rates drop to about 75%, but it's still fairly high. And here you can see the different stages with location. Here's it moves to the lymph nodes, and that's what makes it stage 3. Now, because of that, as children with testicular cancer grow into adulthood, safeguarding their future fertility then becomes a major concern for reproductive medicine. So we can talk about some fertility considerations. And first thing is that even without treatment, testicular cancer is linked to impaired semen parameters, and these can be considered like decreased motility, decreased sperm count, and issues with structure. Issues with structure meaning either their sperm don't have heads or don't have tails, or they're kinked, and they're not motile. And about 50% of adult patients that have a history of pediatric malignancy have struggles with their conceiving children, and that affects their quality of life. And then while most of the boys still have one functioning testicle after the treatment, fertility preservation is still important for those who undergo chemotherapy and who have bilateral tumors. And also, one of the major treatments is a combination of surgical and chemo, so that's important to take. This is just a quick review for us to remember just germ cells. They arise in the embryonic period, and then they migrate towards the developing gonads. They undergo several mitotic divisions, which means that these cells are constantly replicating, and so they're very good targets for chemotherapy. And then just to mention the Leydig cells and the Sertoli cells, the Leydig cells they produce testosterone, and the Sertoli cells are what nourish and help the sperm mature. The Leydig cells are actually fairly strong, and they can tolerate about 20 grays of radiation. And so a child who has testicular cancer, even if he loses or becomes infertile, he can still develop secondary sexual characteristics because testosterone is present. So when we get into treatment and venatotoxicity, the standard treatment for malignant stem cell tumors are surgery, could be either a radical or a partial orchiectomy, and chemo, which it has a combination of bleomycin, etoposide, and cisplatin, or a single agent carboplatin. Surgery is usually combined with chemo. There are other treatments like target therapy, immunotherapy, and radiotherapy. But here important, the chemo from bleomycin, etoposide, and cisplatin combination therapy, cisplatin is the most gonadotoxic. After that is etoposide, and bleomycin doesn't really affect the testes, but it's the combination of the three which intensifies the effect. Now, the impact of treatment and surgery, if it's one unilateral orchiectomy, and that's all the patient has, they still have a second testicle, and in fact, the second testicle compensates and produces extra hormone and sperm as well. If it's bilateral, it's infertility. Chemo leads to oligospermia and azoospermia, reduction in sperm production, and damage in the structure. Radiotherapy, there's different studies. This one that I found says that testicular dysfunction comes when you expose it to about 1.2 Grays radiation units, and there's irreversible damage at above 4. But as I was mentioning, the latent cells are quite tolerant, and they remain intact up to 20 Grays. This is a study of fertility of male survivors of childhood cancer by Green et al., and they demonstrated that in prepubescent age testicular radiotherapy, cumulative doses of more than 7.5 Grays led to reduction in the ability to procreate. And patients included in the study were half as likely to be able to produce offspring compared to their siblings. So it shows how treatment doses and age can also be part of the relevant risk for infertility. So there's different preservation strategies for pubertal boys. The most commonly used is cryopreservation of semen. This is well established in sexually and reproductively mature patients. These are different ways that you can obtain sperm. The most common, cheap option, accessible is masturbation. However, not all patients feel comfortable doing that or have done it before. So there's other ways like electroejaculation, which is under general anesthesia, taking a probe and stimulating the glands, producing sperm. And then we have TESI, TESA, and PESA. TESI is a testicular sperm extraction. It's also performed under local anesthesia in the OR or the office. And basically, needle is inserted into the testicle and tissue sperm is extracted. It can also be aspirated. And in terms of percutaneous, you aspirate from the epididymis. Now, there's other strategies that can be employed. These are questionable strategies in the papers that I've read. And for instance, you can shield the unaffected testicle to reduce its exposure to radiotherapy. There's also the idea of surgical relocation of the gonad that it's unaffected, either to the thigh or the abdomen to protect it from radiotherapy. And radiation fractionation, which is when you take, instead of giving a strong dose of radiotherapy, you give smaller doses, but multiple doses. And the issue with that is it doesn't give enough healing time, which eventually it shows that it's not as protective or preserving as easy as it could be with just freezing sperm. So then here comes my question. So what about prepubertal patients? So prepubertal patients cannot undergo spermatogenesis. This is triggered by FSH and testosterone, and they have not developed everything necessary to undergo spermatogenesis. So in their case, we can't obtain sperm. So what happens? Current fertility options for prepubertal patients are not approved, not validated. They're all experimental. The one that is most commonly used right now is testicular tissue cryopreservation. This is basically taking a piece of testicular tissue and freezing it, hoping that technology, by the time that these kids become adults, has progressed enough that we can use that tissue for their fertility. So in reality, we don't have a set way to preserve these kids' fertility, but we're hoping that by saving this tissue, eventually we'll be able to find a way to allow for them to conceive. Now, right now, there's no evidence for the use of this tissue and for a successful human pregnancy. So everything's experimental, and the cost can be very high. So who has access to this is one of the questions. Now, into the fun part, the advancements in fertility preservation for prepubertal boys is incredible. So I'm going to talk to you. This is a great picture from Gazé and Orwell 2016. It's a great summary. I'm going to talk to you about all the different ways that are being studied I'm gonna skip the first one because our prepubertal kids do not produce semen. So let's start with this one. So after a testis biopsy, you can create a cell suspension, extract the spermatogoidal stem cells, grow them in culture. You freeze that, and then eventually you can reinsert it into, like transplant it into the testicle with the hopes that it would kind of kickstart and start producing the cells, and the patient can have a baby through intercourse. Another way is taking the same cell suspension, and in a process that I cannot explain that well, you make testicular tissue de novo, exposing it to different reagents, and that way you recover the sperm outside the body. This can help with ICSI, which is intracytoplasmic sperm injections for fertility. And then this would be ART, so assisted reproductive technology. The next one, which is personally my favorite, is taking this testicular tissue and do autologous grafting. So taking the tissue, freeze it. When person's ready, they thaw it, and they insert it in the skin or back in the scrotum. Expect that this testicular tissue will grow, and then from the tissue, wherever it's located, extract and recover the sperm, and then undergo ICSI. You can do xenografting in an animal, or you can take that tissue and grow it in culture and hopefully recover sperm from it. Lastly, there's the idea of taking somatic tissue. These are extracting the pluripotent stem cells, creating germline stem cells that you eventually inject into testicular tissue, and the patient could potentially have children through intercourse. Or taking these pluripotent stem cells and growing them to become haplogerm cells and doing ICSI. So all of these things are happening, and it is incredible. These are all different studies. I'm not going to get into the whole thing, but that show you how a lot of people are working on this, and they're getting results. It's just nothing that we can apply right now in a clinical scenario, but in the basic science world, it's very it's growing. And now I want to talk to you about my favorite, which is the autologous grafting. In University of Pittsburgh, in the OB Reproductive Services Department, and with the McHugh Women's Research Foundation, you have Dr. Cal Orwig. He is a PhD, and he is studying male fertility. He's been doing this for over, I think, 30 years. And this paper, the autologous grafting of cryopreserved prepubertal rhesus testis produces sperm and offspring. I'm going to give you some more detail about that, but I just want to say that it yielded the first successful pregnancy in primates, and that's the primate called Grady. Now, in 2021, they, and this is relevant to our patients right now, they took these rhesus monkeys and they did an orchiectomy, they froze the tissue, and then they irradiated prepubertal. They irradiated the area, and then after puberty, also irradiated the area, so they were sterile. And they took the tissue that they had frozen, they thawed it, and they reimplanted, and they produced sperm. So they gave the fertility kind of back to the patient, to the monkey, and using that sperm that was created, they were able to fertilize some embryos. They haven't taken them to the full, art therapy, but they did create embryos, which is definitely, we're getting closer every day. And this is kind of what they did in the first paper. So they took prepubertal rhesus macaque monkeys. They underwent orchiectomy and later a second orchiectomy, so they were completely sterile. The tissue was cryopreserved, later thawed, and transplanted to the same monkey in two places, back in the scrotum and in its back. And that tissue grew, and the sperm was isolated. And using IVF, it led to a healthy monkey called Grady, the first time demonstrating success in primates. So this is the second time that they did this trial. The first mother died with the baby inside, so they couldn't deliver. But this is the second one, and it's alive. And right now they're doing behavioral studies to see how the baby's doing and see if it assimilates well to the community of monkeys that they have. And now, I just want to mention that it's important that there's all this work that's happening right now. It's also relevant in the field of trans feminine children. And I'm adding it for relevance. I think it's important that to consider that these kids who are undergoing these hormonal treatments, they are not able to do spermatogenesis. And everything that we've discussed so far also applies to them. If they're pubertal and they can produce sperm, we just have to consider that they might not be emotionally and willing to do the process of masturbation. So for them, it might make more sense to either do a testicular biopsy and obtain the sperm, or do electroejaculation under anesthesia. And then for our prepubertal patients, we are doing all these experimental techniques that could potentially help them as well, because having gender dysphoria doesn't necessarily mean that they're not interested in fertility and bearing their own kids. And then I don't think I can finish this conversation without talking a little bit about ethics. I think it's part of the conversation. It needs to be on the table. There's a lot of things that we need to consider. For instance, curing the testicular cancer is more important than anything, right? So some might think that this is not medically necessary. It can also put at risk the child for complications, for small risks of infection, and these are things that need to be considered and talked about with family members to make those decisions very clear. It's also everything experimental, so there's no guarantee that undergoing these procedures will, in fact, yield fertility preservation. There's also the cost. This is very costly. Who has access to this? Who is are we going to offer it to all eligible patients or only a particular subset? So these are all things we need to consider when we talk about fertility, and this paper does a great job doing that. They focus mostly on children with gender dysphoria. However, I think it applies to all of them. So just to conclude, survival rates for patients with testicular cancer is high. So as these patients grow into adulthood, fertility preservation becomes more and more important. Testicular tissue cryopreservation helps those youths that are prepubertal, and for pubertal, we can do semen cryopreservation. The ongoing research is getting closer to actionable ways to preserve fertility, achieving success in primates, as I mentioned. Research in this field is also relevant to trans feminine children, and ethical concerns cannot be let out of the conversation. So with that, I just want to acknowledge a few people: Dr. Tasha Jones, Max, Dr. Mortnick, and Honig. They all helped me from choosing the topic to making these slides and kind of getting all the information through. So I appreciate you. Gracias. And lastly, I want to leave you with this quote, which I find very inspiring, by Dr. Orwig. Sometimes we talk about how many people in the world are really impacted by infertility. For me, the only person that matters is the one that walks in the door today and desperately wants to have a biological child. Thank you.
All right. Next up, we have someone who grew up in Peabody, Massachusetts. He enlisted in the United States Marine Corps, where he served as an aviation radar technician and achieved the rank of sergeant. After completing his service, he graduated with Commonwealth honors from University of Massachusetts Lowell, earning a degree in biology. He's currently a medical student at the Frank H. Netter Medical School at Quinnipiac University, where his interest in urology is developed through clinical experience. Please welcome Daryle.
Thank you for that kind introduction, Sam. This morning, I'll be giving my presentation on the review of upper tract urothelial carcinoma. Before I get started, I just want to thank all of you for contributing to an experience that I will ultimately look back on the rest of my career. I felt welcomed, and I've learned so much from each and every one of you. I also want to take a moment to thank Dr. Tan for his support in helping me review these slides before presenting this morning. So thank you, Dr. Tan. So here's a brief overview of what I'll be presenting this morning. So we'll start with diving into introduction, jump into screening and diagnosis, review risk classifications, use literature to guide treatments, discuss post-treatment surveillance, and then quickly discuss challenges in future directions. So upper tract urothelial carcinoma is extremely rare. So it's only comprised about 5 to 10% of all urothelial carcinomas. And in the United States, there's only about 7,500 cases per year. And despite being of similar origin to urothelial carcinoma of the bladder, it's much more aggressive. And this figure on the bottom left depicts that with, at initial diagnosis, more than half of patients having muscle invasive disease. There are many known risk factors associated with UTUC. Men are 3 times more at risk than women. Certain occupations, those with azo dyes and asbestos exposure, smoking and Lynch syndrome are known risk factors, and aristolochic acid was a unique exposure, which is prevalent in Asian countries, particularly Taiwan, where almost half of the cases there are associated with this exposure. So just like other malignancies of the urinary tract, generally patients present with hematuria, but often are asymptomatic. And the workup is, the gold standard workup is CT urogram, which has really good sensitivity and specificity. And additionally, you want to do some type of urine cytology, which lacks sensitivity with the low-grade disease, but has really good specificity. And that can be used in fluorescent in situ hybridization can be used as an adjunct to that. And then, of course, you want to get a biopsy. It's traditionally done with ureteroscopy and biopsy, but I found a paper that investigated the role of IR guided biopsy. It's an interesting topic. It's quite outdated. They didn't include sensitivity and specificity, but they did report an 85% diagnostic accuracy, which shows that there is a unique application for maybe a patient that is not a good candidate for cystoscopy or ureteroscopy. And then with 2 positive tests, you can treat patients for UTUC. So just like bladder cancer, the AUA breaks upper tract urothelial carcinoma into low risk and high risk groups. So the less concerning ones are the unifocal small tumors with cytology that doesn't show high grade, biopsy that doesn't show high grade features, and there's no invasion on CT. And we start to get more concerned when we have high grade cytology and biopsy, we see invasion on the CT, and then there's those rare subtypes of histology present. And also you want to consider multifocal disease, large tumors over 2 centimeters, and then UTUC associated hydronephrosis. So there's a really interesting paper by Van Duren et al. In 2021 that really investigated this population in depth. And this figure here did a really good job of depicting the overall prognosis of UTUC patients. So as you can see here, the low-grade patients have over 90% survival over 5 years, while the high-grade patients have about 80% survival over 5 years. So molecular markers play an important role in urothelial carcinoma. And for example, patients with FGFR3 mutations are associated with low-grade disease, over half of them, which means that this could be a marker for potentially favored prognosis. And conversely, patients with TP53 mutations are highly associated with high-grade disease in more than 2/3 of them. So that could be a marker for potentially a less good prognosis. And then, of course, just in general for screening, MSH2 mutations are associated with Lynch syndrome, which is an extreme risk factor for UTUC. So basically, having these molecular markers that are tied to this disease, you can start to risk stratify and start tailoring treatments, and even in the future, start using immunotherapy to target patients with these specific mutations. So you can't discuss upper tract urothelial carcinoma without talking about bladder cancer. And I thought a perfect way to talk about this was to talk about the molecular biology of the 2 cancers. So despite being from the same origin, this paper, GC et al. In 2021, talked about the prevalence of the different mutations between the 2 cancers. And as you can see here, this is not an exhaustive list, but this is very heterogeneous between the 2 cancers, showing that they behave very differently, even at a molecular level, which shows why they actually behave differently. So here are the AUA guidelines for UTUC treatment currently. So you want to do radical nephroureterectomy for high-grade patients, followed by intravesical chemotherapy. For low risk favorable, you can use kidney sparing surgery, and then you can consider using kidney sparing surgery in low grade unfavorable or even high grade favorable, depending on focality and size of the tumor. And then, of course, adjuvant and neoadjuvant therapy play an important role in the treatment of those high risk UTUC patients. So now, before I get into the literature, I just wanted to break down the management of UTUC based upon starting with localized low grade and then progressing to the more advanced metastases. So starting off, I found this interesting paper that compared the gold standard radical nephrectomy to ureteroscopic ablation for these low grade localized tumors. So Giuloni et al. In this year published a paper that was a systematic review and a meta-analysis and included over 2,200 patients. And ultimately what they found was that there was a statistically significant difference in 5-year outcomes for high-grade patients undergoing RNU compared to ectopic ablation. However, there was not a statistically significant difference for low-grade patients undergoing both procedures, nor was there increased bladder recurrence in these patients. But it's important to note that over 3/4 of the patients that underwent kidney sparing surgery had local recurrence. They didn't talk about the timeline in which that happened, so I found another paper. It's a little dated, small, it's only 40 patients, but they found that after just a month and a half to 2 months after kidney sparing surgery, there was a recurrence in half of the patients, which of course is a huge limitation in this treatment modality. So next, continuing with low-grade treatment, there is chemoablation with mitomycin gel. I know this is a very controversial topic, but we can't talk about UTUC treatment without talking about an FDA-approved treatment. So back in 2020, the Olympus trial had a small study of 71 patients. They found a complete response rate of 59%. But of course, the controversy comes with the rate of ureteral stenosis being at almost half of the patients. Subsequently, a group of researchers, Lindham et al., had an interesting question. And they were wondering, so sure, this chemoablation is effective in treating UTUC, but what if the route could impact the amount of strictures that these patients are having? So what they did was they did antegrade and retrograde treatment, and they didn't find any difference in the complete response rate. But as you can see, there was a significantly lower incidence of ureteral stenosis in the antegrade population, which warrants additional research on this study, on this topic. So now getting into the treatment of high-grade UTUC, there's this very large population study by Sluserix et al. That had over 6,600 patients investigating radical nephrectomy versus segmental ureterectomy. And they ended up propensity matching almost 700 patients in each category. And what they found was a decreased risk of complications, a decreased hospital stay, but of course they had double the positive margin rates in the segment ureterectomy group. The important thing to take away is that there was no change, or there was no difference in survival outcomes between the low risk and the low risk and the high risk cohorts that underwent radical nephrectomy or segmental ureterectomy, showing that this is a effective treatment in even high grade upper tract urothelial carcinoma. So now this is a data study, but again, we can't talk about UTUC treatment without talking about the ODMIS-C trial, which has led us to the standard of care with intravesical chemotherapy. So in 2011, they used mitomycin C versus a control, and they found that there was a 40% risk reduction in the recurrence of bladder cancer with only a number needed to treat of 9 patients, subsequently becoming standard of care. So this year, the POUT trial published their results on the adjuvant chemotherapy post-radical nephrectomy. And what they used gemcitabine in either cisplatin or carboplatin, depending on renal function, and they compared that to surveillance post-RNU. And what they found was an increased 5-year disease-free survival, an increased overall survival, and then no difference in quality of life or toxicity, which show that this plays an important role in the treatment of UTUC. So neoadjuvant chemotherapy was studied in this multi-phase 2 trial last year that compared neoadjuvant chemotherapy and radical nephrectomy compared to just historical data on just radical nephrectomy outcomes. This is a smaller study than the adjuvant chemotherapy paper, but again, it showed really strong, showed really promising results with increased 5-year progression-free survival, 5-year overall survival, and then a really good pathological response as well. Again, showing that this plays an important role in the treatment. So now getting into the sickest patient population in UTUC is the advanced metastases patients. So this year, an important paper was published in the New England Journal that investigated enfortumab vedotin, which is a targeted chemotherapy, and pembrolizumab, which is a checkpoint inhibitor immunotherapy. And they had a population of about 900 patients split into each group, receiving this versus the standard care chemotherapy. And what they found was really important. Basically, a double in progression-free survival, double in overall survival, more than double complete response, and then a significantly increase in overall response rate, showing that even in the most dire patients, we have treatment that is increasing overall survival. So here's the guidelines for surveillance post-treatment. So this is a busy slide. The important thing to take away from this slide is that it's broken up into whether patients have received kidney-sparing surgery or radical nephrourectomy, and whether they had low risk or high risk disease. And with the kidney-sparing surgery, the ureteroscopy surveillance is frequent. And then with the high-grade disease, you want to obviously get chest imaging to evaluate for metastases. So I found a really interesting paper that investigated the role of liquid biopsy or circulating tumor DNA. And this is published last year. And what they did was they collected urine ctDNA, plasma ctDNA, and then compared it to the standard of care urine cytology and CT urogram pre-radical nephrourectomy, and they compared it 2 years post-op radical nephrourectomy. And what they found was a really high detection rate in urine ctDNA that was better than plasma. And then the interesting thing was that every single bladder recurrence patient was found with this ctDNA. And this is compared to urine cytology and CT urogram, which were 60 and 30% respectively. And the really interesting application is that this was able to detect these ctDNA markers 60 days before any other modality was able to, because these other modalities are only able to detect recurrence at the time of recurrence. So there are many challenges associated with UTUC treatment. Currently, chemoablation side effects have really high numbers of ureteral stenosis, despite being FDA approved. And of course, there is a very high recurrence rate of local recurrence rate with kidney sparing surgery. And of course, these patients, especially with kidney sparing surgery, have to go invasive surveillance procedures with ureteroscopy frequently. But the future is bright though. And we can currently start risk stratifying patients using molecular markers. And then we can look at long-term studies to determine what patients are best candidates for kidney sparing surgery, maybe decreasing local recurrence outcomes by picking that right patient population. And of course, enhanced monitoring with the role of ctDNA. In conclusion, personalized medicine is the future of UTUC treatment, using molecular markers to risk stratify and guide treatment options. And refining minimally invasive approaches is paramount in increasing survival outcomes and overall outcomes in the treatment of UTUC. And even in the most dire patients, we have promising studies that show increased survival rates in advanced metastases UTUC patients. Here are my references.